Good afternoon, everyone. Welcome to this new IWC webinar. We are very happy, as always, to see you here. Today we have all the teams, especially Lucian Marcovici, Gustavo Gomez, and we will have Lorenzo and Shihab, who are organizing this webinar with us, and all our friends, panelists. Today it's our pleasure. We are delighted to welcome the team of Istanbul, IWC Istanbul, which is one of the very first team with us in this webinars, and led by Bulent Ozcelik. And we have also the team from Porto Alegre. Is their first participation with Ricardo Kaempf, Brazil. Very welcome, very warm welcome to them. And to all the attendees today, please remember it is very important to take part in the polls, comments the cases, ask questions. That is what make our webinars special, the interaction and the collaboration between you and us. Gustavo and Lorenzo will make sure that all your questions that reach us today, they will closely look at the chat. Enjoy the webinar. I think it's time to give the floor to the one, the only, the excellent Dr. Lucian Marcovici. He will guide us today through the cases, discussion and debates. Lucian, the
Thank,
floor is yours.
thank you very
Enjoy.
much,
Thank
Alam.
you.
As always, I'm always honored to be part of these webinars. We will start with the first case from Brazil by William Brazil. He works with the great Ricardo Kaempf. They are very involved in wrist surgery. And William, can you start your
Hi.
case, please?
Good
Yes,
morning here
perfect.
from Good morning here from Brazil. Thank you for the inviting to me speak today. Before starting the presentation of clinical case, uh, I would like to introduce our team. We are located in the city of Porto Alegre in the south of Brazil. Our activities take place at the Santa Casa of Porto Alegre hospital complex. This hospital complex is made up of 8 distinct hospitals, each one with its own medical specialty. My name is William Brazil. I'm a hand surgery resident at Santa Casa Hospital in Porto Alegre, where Dr. Ricardo Kaempf is my supervisor. Today, I'm going to present the following case to you. A female patient, 45 years old, history of a fall of a chair with trauma on the right wrist 30 days ago. The initial treatment was provided in another seat. At the time, complaints of wrist pain, swelling, and deformity. Here we have the image of the wrist showing ulnar deformity and the X-ray demonstrating dislocation of the DRUJ. In the lateral view, the ulna is seen displaced volarly. So,
So we will start a little bit with the questions now. Muhammad, what do you think is the problem here?
Uh, this is a traumatic drug dislocation with a rare dislocation, volar, which is not common. I think mostly here associated with soft tissue injury as well in the form of a DRUJ ligament or TFCC ligament as well.
Okay, thank you very much, Victor. What would you ask for this patient? Is an X-ray is enough for you, or you think to ask something else?
I think we have to ask for an MRI because we are thinking about soft tissue injuries. We need something else, or maybe some other dynamics X-ray maybe. Because I don't know, it's in pronation. I think that this lateral is a pure lateral. I cannot imagine.
Yeah,
Did,
yeah.
did, did he said that this the lateral is in neutral position?
Yes.
Okay. Okay. So
Oh,
yeah, we for sure we need something extra for the soft tissues.
okay. Ali, do you suspect some injuries in particular? Normally, TFCC tears are dorsal luxated. What do you think about this case?
Yes, there is an obvious volar dislocation of the DRU joint, and in this case, agree to Victor. We need to see an MRI to see the soft tissue, like TFCC may also can injured in this case. Also, there can be luxation or how can I say it? The ECU tendon can pass into the joint. Preventing the reduction. And one more thing, I also want to see a CT scan in this case because it's an acute trauma and maybe there may be some small fragments, bony fragments that can also prevent reduction or need to be fixated. So a CT scan and an MRI should be done for evaluation. Thank you.
Great, great. William, show
Lucia,
us. Yeah,
Lucian, I just have a question. If I can ask all our panelists, if you have one exam other than the X-ray to ask, which would be your favorite exam? Can I ask? Can you ask Lucian? Some panelists. We have I don't know. We have V.
yeah,
We have
yeah.
René, Francisco. If someone can
Yeah.
give us your opinion, what is your favorite exam here?
Gustavo Mantovani,
René, we see
René.
Gustavo and René. René.
Okay.
Hi, René. Hi, Gustavo.
So,
Hello, my dear friends.
Happy to see you.
I say,
What's your,
I
what's
say
your,
hello.
what is your
what would you
opinion?
ask? What would you ask for sure? An MRI or an CT scan?
In this case, I would rather to choose for an MRI because I really would have the curiosity to see how the soft tissues are doing around this dislocation, especially the tendons and especially the TFCC, to see how the interposition looks like. And so I would rather to ask the MRI.
Okay, Gustavo
Okay.
Mantovani, do
Yeah,
you agree?
yeah, that
No,
was me.
Gustavo. Yes, it was Gustavo, not René. It was Gustavo. That
Yeah, yeah.
they
Okay.
have the same voice. They have. René, do you agree with this?
René, do you
It, it,
agree?
the same voice, huh? Okay. In my opinion, I think that is a very good option when I use the X-ray and CT scan is for me is a very good exam. That in this injury when we have a compromise of the components in the exarticular, interosseous, oblique band or radioulnar tract, and compromise of the TFCC is, I think that CT scan and axial projection, for me, is very good.
So we
Okay.
understand that where are you, Lucian? We understand that the ideal thing would be to have the CT scan and the MRI. CT scan for the bones, the
Yeah,
fraction, and MRI for the soft tissue. You can go
Yes.
on.
yeah.
Sorry.
So, William, go on, please, with the case.
Just please, I will show you what told our panelists for the imaging. 73% of the panelists would choose the CT scan in this case. Okay, just to tell you, you can go on. Sorry,
Go
William,
on,
you can.
William.
Yeah, let's continue. So, the symptoms of volar dislocation of DRUJ are ulnar pain, blocking of pronation supination movement. The X-ray shows in the anterior posterior view superimposition of the radial board of the radius of the distal ulna. In the lateral view, the ulna appears in a volar position relative to the radius. And dislocation of DRUJ is the hair. It usually associated with fractures, classic Galeazzi fracture dislocation, and dorsal dislocation is more common. This occurs due to the hyperpronation failure to the reduction maneuver usually happens because of soft tissue interposition. The ECU is the tissue most frequent interposed. Specifically regarding volar dislocation, in the study by Garrigues and Aldridge conducted in 2007, it was demonstrated that dislocation caused a osteochondral impaction fracture of the ulna, similar to a Hill-Sachs lesion of the shoulder. Here we see the CT image showing the impact fracture of the distal ulna against the radius. Next to it, we see the MRI with the ECU tendon completely free and outside the area of bone impaction, indicated by the yellow and green arrows.
Okay.
So,
let's go to the therapeutic options. G, are you with us? How do you think to manage this kind of case?
Well, it's a tough case there.
Only tough cases in EWC webinars, you know?
Yeah. I just want to know, like, what's the yellow arrow? Is it a soft tissue interposition of ECU tendon?
It was then ECU tendon completely free, I imagine, no? With a great tenosynovitis, right,
Yeah.
William?
right, the ECU is totally free.
Okay, ECU is totally free. Okay, well, I would try to do, well, this patient definitely needs to go for surgery. So I'll probably put this patient under general anesthesia to try to see whether if I can manually reduce it when the patient is relaxed. And then, you know, if we can manually reduce, because sometimes when the patient is awake, there will be a block of pronation, supination. So when the patient is more relaxed, we see whether if we can do a manual reduction. If we can do it, I'll probably put in the scope to take a look. But if I can't reduce it, I would also attempt to put in the scope, radiocarpal first, and then followed by a DRUJ scope, just to see whether if there's any osteochondral fragment that's affecting attempted reduction, basically using the arthroscope in the DRUJ joint. Yeah, that is what I'll do. But if I couldn't reduce it, then I'll proceed to open.
So you will put the scope in the dorsal DRUJ joint?
I would attempt the dorsal first and then probably try to create a volar DRUJ scope, because I think the dorsal will be best because the distal ulnar is actually over the volar area.
Okay. Okay.
Yeah, that's what I'll do.
Fabio Tendioi, share with us your opinion, please. You're with us, Fabio?
If there is someone
I am
else
here,
that
but yes, I arrived late. Please repeat me the question. I believe
How
it's in
would you manage this kind of case?
okay. It's important to put the scope in radiocarpal joint to know the damage around the TFCC, because sometimes radioulnar dislocation has a injury of the TFCC on the foveal area. Then go to under the TFCC in the radioulnar distal portals to know about the injury of evaluate the chondral lesion and check the TFCC.
Okay. Okay. Gustavo Gomez, can you share with us your feeling?
This is so interesting case they bring to us. Thank you for the guys from Porto Alegre. You see the ECU is exactly on the middle of the way, but in fact, I don't think the ECU is the problem for the reduction. The reduction is easily stuck by the bone impingement. So I agree with that. I think maybe during the general anesthesia you can relax the patient and make some closed maneuver in order to make no attention to reduce it. But mostly what I think it's locking this the ulnar head is all the unocarpal components are torn, and the soft tissues, the volar soft tissues probably are in the between. So including the maybe parts of the PQ muscle. So I would try to make this closed maneuver. Then I will put the patient in traction in the arthroscopy traction. I would expect, as Fabio says, by the radiocarpal joint, by the before, to see how it looks like, and depending of the image, probably I'll find the TFCC okay on the top and the ulnar head below it dislocated. So I would try to make my dorsal radioulnar portal in the between this. Probably going to find the ECU in the middle of the way. I don't know. I would I will check in the OR during the arthroscopy to see. It probably will be as difficult as a perilunate dislocation sometimes. A more old perilunate dislocations, you have the lunate volarly in same kind of situation, and you have tried to deal it with the arthroscopy. But I would try the closed and arthroscopy way first, and after, of course, if it doesn't work, try to open it.
So I had a case, a similar case. Ricardo Kaempf knows it, and I really found that there is like a bone lock when you see arthroscopically this situation. So I don't think you can reduce it because it's like the bones enter in each other, like the volar ridge of the radius enters to the ECU canal, and they lock each other, and it's like not moving anywhere. Gustavo Gomez, what do you think?
Well, I think hi everybody. Good morning for me
Hello,
and good
Gustavo.
afternoon for you. How are you doing? Well, the thing is that we have, I think, in these cases, I have done a few ones. You have a lot of fibrosis in the middle of the sigmoid notch. And the other thing is that you have a mechanic engage between as you said, Luciana, and I totally agree with you. It's very hard to disengage this because the volar lip of the sigmoid notch is completely stuck on the ulna. So sometimes by arthroscopy, if you want, you can introduce a tool between the ulna and the radius, and you have
Like
to
a curved
make some
sphere, like a curved.
exactly, and you have to make sometimes a lot of strength in order to move the ulna out of the way, and after you disengage, the ulna tends to go again inside the sigmoid notch. That's my experience. It's very difficult to disimpact this, to disengage.
Gustavo, I have a question for you because a long time ago, my professors for this, to Gustavo and other panelists, they used to tell us we tried the close reduction in the OR, and after it doesn't work, if it's under tension, if it's dislocate again, we used to put key wires. What is your opinion about the key wires? How it works for you, putting radioulnar key wires to maintain the reduction? It's a
So I'm going to be very short. I don't like it.
Yeah.
I
Because why?
totally
Because
agree.
it doesn't work. Because it doesn't work. Because there is a recurrence of the dislocation. Why? Because for me, the main issue with the key wires is the recurrence after. What is your opinion about this?
In my experience, after you disengage this kind of deformity, it's very difficult to have a recurrence because this dislocation happens just in the moment the patient falls over the floor. So it's very difficult to have this kind of engage again just with a movement of the wrist. I don't think you will have a recurrence with this exactly the same deformity. So I don't think it's necessary. For sure, the patient is going to have a instability of the DRUJ, but I don't think you're going to have a recurrence of this kind of dislocation unless the patient fall again over his hand. And the other thing is that you have a lot, you know, unless you put a very wide keyword, you have a lot of risk of that this keyword breaks. And this is a very complicated situation because you have
Yes.
to open the signal notch in order to take out the part of the keyword that is inside the radius. So it's very, for me, it's unnecessary and it's very risky.
Thank you. So
Thank you.
Yucel,
So
I
we,
think.
yeah, I think we can continue with the case, William.
Yes, let's continue. Okay, so according to the literature, the initial treatment consists of close reduction and followed by immobilization with the forearm in pronation for 6 weeks. In case of instability of reduction, the temporary use of percutaneous fixation with Kirchner wires has been described. Uh, so, in this cadaver study, Demerol demonstrated that a complete dislocation of the joint is impossible without injuring a portion of the TFCC. Our colleague Dr. Etze in this study describes the arthroscopic repair technique for foveal lesions of the TFCC associated with stability. Also, in his review article, Dr. Etze presented the iceberg concept along with the treatment algorithm of Palmer type 1B TFCC lesions. The idea presented here is that visualization of the TFCC lesion through the traditional arthroscopic approach underestimates the problem. One may notice the perforation in the TFCC, which represents only the tip of the iceberg, but by visualizing through the DRUJ arthroscopic portal, the foveal lesion and the underlying cause of the instability are revealed. So in this case, the plan is close reduction and arthroscopic reinsertion of the foveal lesion of TFCC. In the surgical procedure, we use a traction tower, 2.7 opticals, 2.9 soft tissue shaver, and a radiofrequency probe. The close reduction maneuver is performed on the traction tower with a hyperpronation of the forearm and the distal ulnar compression from volar to dorsal. A click is felt at the moment of reduction. Here we have the video demonstrating the maneuver. During the video arthroscopy through the radiocarpal portal, we first observed the distal TFCC intact, as seen in images A and B. In images C and D, using the DRUJ portal, the foveal lesion is identified. The lesion is then repaired with transosseous suturing, as shown in images E and F. Here the repair. And here the final result with the clinical image of the wrist and showing the postoperative X-ray. We conclude the importance of arthroscopy in the treatment of volar dislocation of the DRUJ. It assists in joint reduction, testing stability after reduction, and also in diagnosing and treating TFCC lesions. We suggest the use of arthroscopy in patients with acute volar dislocation of the DRUJ who present instability after joint reduction, as well in patients who cannot remain with immobilization. Additionally, we recommend for patients with chronic lesions or irreducible injuries that will require reduction in the operate room. So, thank you today.
So thank you very much. Let's speak a little bit about post-operative management of this case. Bulent, can you share with us your feeling? How will you manage this case in the post-operative?
I think that the reduction has to protect for 3 weeks with a long arm cast. After then, we have to start the physiotherapy as possible as we can after 3 weeks. Because the supination and rotation problem is very hard to resolve. We have to start physiotherapy as possible as we can. It is very important to get a rotation again. And the treatment process, I generally add some other things. We published it ECU turnaround ligamentoplasty, and the protection of the volar dislocation is much more easier with ECU, and it helps to continue reduction after the distal radioulnar joint continuity. And I think that it helps us to start physiotherapy earlier.
Okay. Gustavo, I know that there are some comments from the chat.
Yes, Juan Varela said, I will try close it using lamina spreader as thinner paper if reduces. Then I will scope and check the TFCC. And Paula had a very similar comment. I will put it under anesthesia and traction, try to reduce it, and then check the TFCC by arthroscopy. If luxation persists, dorsal approach and release structure in between.
I think Pedro has a comment. Hello, Pedro. Thank you for joining us. How are you doing?
Hello. Sorry. Sorry for late connecting. Okay. Very interesting case, but in this case, I think it's not a simple case, okay, because it's not a classical or geological TFCC proximal foveal tear, because it's like a mix of TFCC rupture and ligaments rupture also. Probably in this case, I not only repair only the TFCC, also try to repair the ligaments. Okay, and also as the previous speaker said, I think it's more important to have to take rest. In fact, about the postoperative treatment, I think the best is to treat like a ligament reconstruction, not only like a TFCC reconstruction. Probably in this case, I add not only a TFCC repair, also a ligament reconstruction or something to try to fix the joint more proximal, like the distal orbital bundle or anyone. This is only my suggestion.
Pedro, what is the place of the open surgery here? In your opinion, the chronic cases, irreducible.
Yeah.
Do you have experience for the open surgery, please?
Yes, this is a good question because when you are a arthroscopic surgeon, it's very easy to us to speak on treating only with arthroscopy. In this case, we have to take in mind we have arthroscopy is only a tool to improve our results. But in this case, it's a combination with open treatment to try to reduce the reduction, because probably in this case, the location is very, very extreme. We need to perform something with an open or minimal open approach, and arthroscopy. In this case, a typical case to treat using a hybrid surgery, not only arthroscopic or not only open procedures.
Okay, thank you. Bulent has a comment. Sorry, Lucien.
ECU is a very well known protector for the distal radioulnar joint. And I think that we turn from the styloid and fix it from on itself. And it helps to distal radioulnar joint stabilization. And in that case, you could remove the cast easily, and you don't need to fix the distal radioulnar joint with key wire. And it always be in there. That's why the UCU is very helpful to get reduction and stay in this position. Thank you.
Okay, it's very
Great.
interesting, Joe. So I think we will close the case. It's really interesting to see that for our polls, half of the attendees, they vote for the open reduction with ECU chest and DRUJ stabilization for open reduction. So just to share this, Lucien.
No problem. Let me introduce myself first. I'm an orthopedic surgeon who has engaged with this international risk center team like almost 1.5 years ago. And I'm focused mostly on, of course, hand surgery. And I'm so happy and glad to join this team. So the case we will present today was operated almost 2 years ago. We collected the data and I'm going to try to present this case for you. This is a 36-year-old male with right hand dominant with ulnar-sided wrist pain and discomfort. He had mild tenderness over the wrist joint and no history of trauma. These are the clinical photos prior to surgery upon examination. And this is the range of motion videos before the surgery. The main problem was tenderness and mild swelling over the ulnar side, as you can see. So upon arrival, we obtained an X-ray. And shall I proceed, or you will?
No. Now we will. I want to ask Paula. What are your impressions from this X-ray, Paula Ramirez?
Hi, Lucian.
Hi.
I think the carpal bones doesn't look like right. I like maybe it's the reaction of the X-ray. I don't know if it's intends to be a hand or wrist X-ray.
Yeah.
And the base of the fifth metacarpal bone, it seems oblique as well. But clearly, because of the presentation, you can see like a shadow image of the
Cannot hear you.
Paula, we don't hear you, Paula.
Now, Paula, we cannot hear you. So maybe we can ask someone else for this. We have no, we cannot hear
we
you.
don't hear. So, Victor, what do you think?
Hi, I don't know. With this X-ray, it's hard to see something special. You can see some kind of calcification down the distal radioulnar joint and so on. And but I think we need as you ask in the poll, I will go for MRI to see the soft tissues and so how this kind of tumor can be and what is involved in what the structures involved.
Okay.
Okay.
Someone will do an ultrasound in the office before it or something like this, or some other checks.
When I see this, personally, I go directly to the MRI because it looks like a cyst, but sometimes we can have surprise. I would like to avoid any surprise, especially for a giant cell tumor. I think it's not really frequent in distal ulna, but I had once a case which was in the beginning not so obvious. So I X-ray directly to a very good MRI with specialized radiologists. I don't know what thinks the others.
Okay. Somebody will do an CT scan, or MRI is the common way of thinking.
I think
Okay. Yeah.
Fabio has a question.
Fabio?
Yes, when I have these cases and the patient have a ulnar pain area, I ask always MRI, X-ray with a elbow 90 degrees, shoulder abduction 90 degrees, and hand improntation to know the longitudinal, the long of the ulna bone with a radius bone to rule out any impingement. Is a good option too. First to know about the MRI too. In my
Okay.
opinion, MRI is a good test too.
So continue, Yucel. I think everybody's thinks that you should continue with an MRI. Let's see what you asked.
Well, we actually asked for first a CT scan because we obviously there was a radiolucency in the distal ulnar part where the patient had tenderness and the complaints mostly. So we proceeded first with an CT scan. Why I cannot?
Okay.
Okay, this is the CT scan.
Okay.
As we can see, there's a clearly shaped lesion in the distal metaphyseal ulnar region, as well as the dorsal part of the distal ulna. In some parts, it reaches to the joint line in a small area. And also we ask for MRI. In MRI, to classify this cystic lesion, low intensity, low signal in the T1 images, and in T2 and fast suppressed images, it's high signal intensity, as you can see. So based on these findings, how would you proceed? We had several options.
So let's ask Francisco Malibowski. Are you with us? Francisco? Hello, my
Hi.
friend. Happy to see you.
Hi.
Hello,
Yeah.
Francisco. How are you?
How will you manage this kind of situation, Francisco?
Yes. Usually, oh, excuse me. I'm at the airport, so sorry for the connection. Usually, I do on a scope in this case. I think so. I try to see what are my findings in the TFCC, and I do surgically. I I think I could put a graft of distal radius I think I will do all in arthroscopically way.
Okay, okay. So, will someone from the panel will do a biopsy first?
It
What do
depends
you
on for medical legal reason. For me, it looks like obvious here, but we need to have a specific radiologist who put written on a paper it is benign intraosseous cyst because it looks like this. Just my advice for medical legal reason, I would not ask for a biopsy, but since it is obvious, I would like the radiologist to write that is benign intraosseous cyst.
Okay, so
I
I
don't
want
know.
to ask. I want to ask if the TFCC is perfect, it's easy. But if the TFCC is lesioned, it's easy to arrive in this area. But if the TFCC is healthy, how you approach it? How do you approach arthroscopically this kind of situation? Gustavo Mantovani, can you share with me your opinion?
Yes, for sure, Lucian. Hi, everybody again. I would try the DRUJ distal portal. I think try to check how it looks like. It seems like the connection of this cyst with the joint seems to be mostly in the distal part, in the foveal attachments. And in this portal is very important as well because there is some cystic changes in the radius as well. So I think in this case it's paramount to address the quality of the DRUJ cartilage and conditions. And arthroscopy for sure will be my option. It's a perfect diagnostic tool to understand why this interosseous cyst is forming and what is the possible etiology. It can be some chondrocanosis situation. It can be some arthritic or inflammatory reactions around. So I would go this DRUJ distal portal and check it. If the
Okay.
TFCC is okay. Otherwise, you can probably see around in the middle of the TFCC central injury if there is a big injury.
Okay, so let's continue.
Okay, so we chose a surgical option, an arthroscopic procedure as a surgical option. We chose. Just a minute. So we first started with, as you said, evaluation of the
Yes.
TFCC.
Okay, and after you go back, can you see? Can you see?
Yes.
Yeah.
Okay, so you can
Yeah.
comment. Okay.
So we first started with dry arthroscopy, and we evaluated the TFCC, and then debrided some part of it, and then through the we entered the cavity through with the shaver, and debrided the inside material. There are 4 videos. I cannot see your screen, so that's why there are 4 different videos of the scope.
Okay, here we are debriding the TFC. Okay, yes. And after okay, after we see the X-ray. Okay, up. So we see the debridement with the curette
yes, the
inside
curette
the
with the
cyst. Yes,
on the right. On the right.
Inside the cyst with the camera in the 3-4. The curette is in the 6R here, and we see the debridement at the curtage arthroscopically of the cyst. We see with the curette we can empty and curette debride totally
you can
the
see
cyst.
the bone marrow bubbles coming out of the bone.
Yes, exactly. And after we go for the grafting options.
Thank you. We ensure the correct place, and then we use curette.
We also already have seen this, right?
Okay. So after emptying the cavity, we need to fill it with graft. So we had several options. For autograft, in majority of our cases, in upper extremity, we use olecranon grafting. We make a stab incision just over the olecranon, and under fluoroscopic control, we can obtain a high amount of cancellous bone, which we can adjust to fit the cavity. And it causes almost no donor side morbidity with this small step incision. And now the challenging part is to put this grafts through the cavity using the arthroscope, because those parts are so big pieces. So we cut them into pieces, and using aspiration catheter, we adjusted it in the appropriate size, and we cut the graft into small pieces, and using this catheter as a tube, we introduced all of the bone grafts into the cavity under fluoroscopic control. Here another video. Yes, it plays. You can see you will see now the aspiration catheter going through the cavity. And the bone grafts are pushed inside it, through it. And the position was always checked with the fluoroscopy.
Okay.
We also checked the mid-carpal portal, mid-carpal joint, and there was SL and LT problems. So we did dorsal ligamento-capsulodesis for both SL and LT joints. And the final X-ray final fluoroscopic image was this. The cavity was fully packed with the grafts. This is the X-ray after 4 months. And at the end of 2 years, you see the graft was perfectly matched with the area. And the patient was living very far away. So we just asked for a video from WhatsApp. So that's at his original home. But there's no limitation in pronation and supination, as you can see. When we check the literature, we see in Rizzoli case archives, the lesions in ulna are extremely rare, like almost only 1%. Pseudotumoral lesions, like tumor-like lesions, or all benign tumors, it's almost 1% for ulna. In other studies, they reported almost same results. In a single center study from Turkey, 3,500 cases, but only 23 had primary ulnar involvement, even less than 1%. Most common osteochondrome and aneurysmal bone cysts. So the pathologic specimen was reported as a unicameral bone cyst for this case, and those are mostly dysplastic or reactive lesions rather than a true tumor. And for this kind of lesions, it's always recommended curettage and bone grafting for healing to prevent pathologic fractures and restore cortical thickness. So we use arthroscopic management, which provided us direct visualization and assessment of intraarticular pathology with minimal morbidity. As a conclusion, in ulnar-sided wrist pain cases, although it's rare, ulnar cysts should be considered in mind, and arthroscopic curettage combined with bone grafting may provide effective and minimally invasive treatment option. Thank you.
Thank you.
Thank you,
Very
Yucel.
good.
Very,
Can
very
you
nice case.
stop sharing your screen, please?
Yes.
Yucel, please.
Yes.
We have a lot of questions. I love this.
So, what do you think, panelists? What do you think about this case, the management of the case? Do you have some comments?
Yeah, we have Gustavo Mantovani, Victor, and Fabio. They want
Yeah. So in my screen I see first Fabio. So let's start with Fabio. Fabio.
Thank you, Lucien, and thank you, Hanan. No, in this case I prefer use arthroscope to diagnosis of the injuries around this cyst, and but probably if I were you, I use the lateral approach after the diagnosis, lateral approach in the ulnar bone to curettage the area of the injury, put for this approach the bone graft. Because I prefer don't damage the cartilage in the distal radioulnar bone.
So you will do a hybrid approach, arthroscopy and open.
Mix,
Gustavo Mantovani,
exactly.
what do you think?
Thank you.
Yeah, no, the question is about similar because I found this very innovative and clever way to treat the cyst. I see the similar experience Alan has with Christophe to the intraosseous cysts in the lunate. I have some similar cases, for instance, for similar cysts in wrist arthrosis in the basis of the first metacarpal. We can also address inside the cyst by the arthroscopy inside the joint. So it's a very clever way. What I miss in this case, and I would like to ask to our colleague, is the diagnostic part. How was this DRUJ? How was all the ligaments around to understand this pathology, not to treat exclusively. You have this prior diagnostic, no, this is a benign cyst, and I will treat the cyst and forget all about. And we do not use the power of the diagnostic that we had in our hands. So that's my question. If it was used, it was not just said here, but or not, and why?
So Yucel, Bulent, can you answer him? As the case is yours.
Yes, we haven't got any distal radioulnar joint instability. It is the first point. But we have a swollen wrist in the ulnar side, and we check the MRI and CTs, three-dimensional CT, and sometimes we add some 4D dimension and to check the stability with the 4D. It is very helpful to get some opinion about the distal radioulnar joint stability. And we know that it is a basic unicameral cyst, but it was very big. And we try to get the graft on it with arthroscopic way. And if you open it, we have some problem about the restriction of the distal radioulnar joint activity or mobility. That's why we don't want to open it. And it is we appreciate that we could manage it with arthroscopic way, all arthroscopic way, and the results is very well after 4 years, 2 years, pardon, and I think that we have to check the stability first. If we have a problem, yes, we think that we we need some other options to get stability with ligamentous site. But in this case, we don't need it, and it works.
Thank you very much. Victor, you had a question?
Yeah, I have two comments. Well, first of all, congratulations for the case. It's a very interesting case, and I will do the same. Actually, I will do the scope. I will check everything, and well, the only thing maybe I will do it the dry arthroscopy because it can be a bit messy when you go in and you are trying to remove all the cyst. And the other thing is that I agree with Gustavo Mantovani because sometimes it can be an error of diagnosis because when we saw it, I can remember that we can see a central lesion of the TFCC, also a lunotrigetal ligament injury, and maybe in the last X-ray we can see that maybe can be a bit ulnar plus or maybe some kind of ulnocarpal implantation. So I think we have to think about the more of the diagnosis that we more than just resolve the cyst. So I will ask you if you have any comments about that. If there's something else that can create that cyst. The other injuries that we found in the arthroscopy can be related to this case, or what do you think?
I think that is the main problem when we have an ulnar-sided pain. We can have many anatomical lesions that we see intraoperatively, and it is difficult to correlate the symptom to the lesions. So the arthroscopy, yes. So for me here, the main problem is we see it's an obvious cystic lesion. We did the MRI. We all agree on this. The arthroscopy is an original and elegant tool to do the curettage and the treatment of the cyst. But as Gustavo Mantovani said, for me, it's a very, very important to check the other associated lesion, not differential diagnosis, because probably the cyst here, since it is a big cyst, is responsible of the pain. But the arthroscopy is important to treat the associated lesion intraoperatively, especially the TFC, as you said, and the LT ligament. That's the arthroscopy is elegant way to treat the lesion, but it's for me very important for the other lesions because we can have a set of lesions that explain the pain. And after, if you treat only the cyst, maybe the patient will have a persistent pain because we missed that we didn't treat another associated lesion. That's my opinion.
Yeah, exactly.
Sometimes do not even do mid-carpal arthroscopy. For me, I used to say this, Alan. You make it a perfect comment for me, to my fellows. Doesn't matter what is your primary diagnostic. When you are in your OR with the arthroscopy, you must take advantage of the full power of this tool. So make at least the full joint inventarium, at least the four main portals, the mid-carpal portals and the radiocarpal portals, especially for ulnar side pain. No?
Exactly.
Bulent, your comment?
The central part of the TFCC is not important for the stability. That's why we can remove the central part as if we need. That is the point of mine, and the stability affects with the peripheral side of the TFCC, and you can remove if you need. You can remove the central part. I saw when I was in France the central part debridement in Paris. That's why, and the other issue is to reach the ulna distal part is not easy. You have to damage. You have to damage all of the structure, soft tissue structure, And with arthroscopic way, it's not necessary. It is easy to reach the distal radius, and it's possible.
Bulent, I have just a short question to you and the others. I saw from the 6R portal, your hand was vertical. Do you
Yes.
recommend, as we have in the TFCC foveal reinsertion for Gessler technique or Fontes technique, do you recommend an accessory portal? Because sometimes
Yes.
at the 6R portal, you are so vertical, you are pushing to the dorsal side of the wrist. Is it the best
Yes.
portal, arthroscopic portal?
Yes, generally, you have to see the opposite side of the working place, and it's very close. And you can use 6R and 6U in the same time. And we use the 6R for the viewing portal and 6U for the working portal. That is the point. And we have a case in the lunate ulnar sites. And in that case, we use the 6U to viewing portal and 6R to working portal. And it is easy to see the lesion and to work with the other side. And
Okay.
in the same techniques we use for the scaphoid fracture, and we use MCR portal to weaving portal and scaphoid portal. We describe the scaphoid portal as working in the fracture line in the distal site. Thank you.
Thank you, Bulent, for the comments. I think if there is no other comment, we can
Okay.
go to the chat. Huh? Yes. Thank you.
Yes. We have a question from Rio Wardhana. How about recurrence rates after curettage the cyst, then fill with bone graft or bone substitute? What is the best? And if it is recurred, how we can manage?
My choice always biologic reconstruction from the patients, but I haven't got any other options to other the other methods, but I always use the graft from the patients, autograft.
I think the
Okay.
most the recurrence rate is high when we use the non-surgical option. When we use the aspiration and injection for non-surgical, the just like the dorsal arthrosynovial cyst that we have. That's my opinion.
Right. And the other question, I think it was already answered from Kantan. If we don't have a central TFCC rupture, what's your management? So I think we have talked about this. I don't know if anybody has
You can
one.
we have two options. One of them is distal radioulnar joint arthroscopy. You can go on the up and you can see the distal ulna easy with the distal radioulnar joint. But the other options is to remove the central part of the TFCC. You can remove it without any mechanical problem, I think.
Okay, thank you very
Okay.
much. Alam, can you conclude?
Yes, thank you, everyone. I think there is no other comments. Thank you to the two teams, Porto Alegre and Istanbul. We are sorry Ricardo Kaempf couldn't join for technical issues, but we had, I think, all the comments that he wanted to tell us here. So thank you for the young speakers. The presentation are very great. Thank you to the panelists for the good comments. For the next steps, thank you to the attendees, of course, for being with us. For the next steps, we have November. November is really, really full of events. We will have the Regional Club on November 13. We will have, I think, the Clinical Case Symposium just like today on November 22. And one of the most important events of the year, which is the Seasonal Risk Forum. We will be all together in Strasbourg for the course. And we will launch from Strasbourg live our Seasonal Risk Forum with lectures, cases with the experts. So please follow us on the social media and LinkedIn and Instagram. We have there all the links and to register. And what to tell. Thank you, everyone. I hugs and enjoy your weekend and see you very soon. Bye bye.
Thank you, everybody. Thank you. Bye
Thank
bye.
you. Thank you.
Bye. Thanks.
Bye
Ciao.
to everyone. Bye bye.
Thank you. Goodbye, everyone.